I apologize in advance if but maybe the first 4 or 5 minutes of my talk will be a little bit of a repeat, something I did earlier. But I'm going to talk about intratumor heterogeneity and its impact on the care of the patient. See, the Mac, Joe, I got the Mac one, and it works great. And I just couldn't keep watching you like that, and it was killing me.
It's just like residency.
Well, I don't know. So anyway, I do have a disclosure just that the math process I've submitted, and there's an active patent. Oh, you know what? I spoke too soon. See that? And he promised me it would work. There we go. So I think we all know that tumors follow branch Darwinian evolution. Do you think you could do anything about this at all, or is this how the talk's going to go? I think he had the exact same problem, though, right? Weren't you kind of standing like this for a significant portion of it? So I think that next generation studies have clearly demonstrated that cancers share common clonal origins, originating with early founder mutations. What was that movie when he had the...
You have to shake your body.
Let me see if I see someone's head there. Maybe if I go this side. No? Which one should I use now?
Next slide, please.
Oh, there it goes. And that subclones are defined as mutations that occur later in cancer evolution, occurring some cells, not others, and multiple subclones can coexist within the same tumor or intermix within the same biopsy. We'll talk about that a little bit. Next slide. So I can tell you that every single bullet I have has to have this work, so you're going to have your work cut out to you. So intratumor heterogeneity results in tumor subpopulations able to survive, proliferate, spread, resist treatment failure. Next slide. Next slide. But basically what this means, so now you're going too fast, go back. I'm telling you, it's going to be tough. The technology's failing. So it's a homogeneous tumor, fewer cell populations, they're sensitive to therapy. Treat with radiation and chemotherapy, you're going to get cured. And it's really the statistical, this is an important point, I think, it's the statistical likelihood that there's a resistant cell there, okay? So the next slide, if you look at a heterogeneous tumor, more cell populations, and now more likely to have a resistant cell population. That doesn't mean that, sorry, I'm just trying to get closer to the microphone. But the end result next is that it often results in treatment failure. Next slide. So we need a quantitative measure of intratumor heterogeneity. Next slide. So high-resolution genome studies have revealed significant genetic heterogeneity within tumors. Next slide. Tumor genetic diversity associated with metastasis treatment poor prognosis. Next slide. So a quantitative measure of this, of intratumor heterogeneity, would provide significant information that could predict outcome in direct therapy. Next slide. So we saw this before, but this was basically the Hopkins group and the Pittsburgh and Broad group. Both did sequencing of a number of head and neck cancers. Next slide. And so reported as yes, no here by the Hopkins group, but next slide. The Broad group really reported this as mutant allele frequencies. And so when you report things as mutant allele frequencies, remember when you do exome sequencing, let's say there's 100 reads at a single exome. If 10 out of 100 have it, that would be 10%, okay? And that's where we got into these conversations about if there's contaminating cells or this or that. But this allows you to follow a branched evolution model, and I think that's important. So next slide. So this is that mutant allele fraction we talked about. All reads at the locus of an exons versus the reads with the mutation. That's your mutant allele fraction. But imagine if, and next slide. This is influenced by mutated copies per cell, relative size of a subclone. Next slide. And here you have to worry about copies per cell, relative size, and normal cells in the sample, like lymphocytes and other things. Next slide. So this is how math works. Next slide. So imagine a homogeneous tumor, mutant and normal alleles. Every single one has the same thing. Very idealized. Next slide. No contaminating cells. And the mutant allele fractions, every single one is going to be 0.5. Next slide. And the distribution of that's going to be very narrow. And the median, which represents the mutant allele fraction, is going to be about 0.5. In contrast, next slide. A heterogeneous tumor now. Next slide. You can see that maybe for this gene, it's there half the time, but this one's 0.3, that's 0.2. Next slide. You're going to get a distribution that's much wider, and your mutant allele fraction is going to drop. And so you would say in this idealized setting, this is a homogeneous tumor, and this is a heterogeneous tumor. Now remember, When we use exon sequencing, we're looking at 36,000 exons, usually an average read depth of 100 to 150. So you're getting a huge amount of information. Next slide. So next slide. So these are representative scores. Next slide. Here, a homogeneous tumor, narrow distribution, up around 0.4. Next slide. Heterogeneous tumor, wider distribution, around 0.2. So kind of fits the hypothesis. Next slide. So we did that, we validated it, we did that, it worked really good. So then we just recently validated this, is what I presented earlier, using the head and neck TCGA data sets. Interesting, I'm the third person using the TCGA data set, so I think the government actually did something good with our money for once in paying for this. So anyway, next slide. But basically coming in, we do our math analysis. And one thing I will point out, I'm not going to show it here, but math has no relationship to the number of mutations in a tumor. It's measuring something differently. Next slide. So basically in our training set, which was the Stransky paper, 74 patients, math, next slide, had a hazard ratio 2.5, next slide. But if we look at the TCGA, we now have, next slide, similar hazard ratio, but a lot more patients. And next slide. So the 10% increase in math correspond to an 8.8 increased risk of death. And these were all the different sites, all lumped together, all different treatments. Next slide. So one of the early observations we had in the training set was when patients were treated with chemo radiation, there was a strong impact of math on the hazard ratio. And this is really an actionable hazard ratio, but worried about the small size. Next slide. When we looked at patients we could document treated with chemo radiation alone in the TCGA data set, we saw a similar response. And we think that this has a lot to do with the fact that the subclones themselves, it's a probability of having that resistant clone there. But basically, if you have a high math score, you shouldn't get chemo rads, in my opinion. I'll talk more about that later. Next slide. So that's kind of math. So we have this quantitative measure. We developed it with the Stransky data. We validated it in the TCGA data in a very unbiased fashion from 14 different institutions. So how can we use it? So next. Next. So we want to use it to identify oropharyngeal cancer patients for treatment de-intensification. Next slide. We want to prospectively validate it. That's going on. It's funded by the NIH. Next slide. We want to potentially use it to direct therapy. Next slide. We want to use it to improve tumor models because our tumor models stink. Certainly our cell line models stink and our xenograft models are a mixed bag. Next slide. I want to talk a tiny bit about tumor spatial heterogeneity and targeted therapy. And finally, next, examine the origins of intratumor heterogeneity. And next, can you actually target heterogeneity? Could having heterogeneity actually be a weakness? Kind of like you can't run fast and a lion's going to get you in the jungle, you know? So next. So when I think of HPV-related head and neck cancer, I love this. This was TAX 324, phase 3 trial, induction chemotherapy followed by sequential. It was, lots of toxicity, great response rates. And basically HPV-positive patients did great and HPV-negative patients did, well, Joe Califano really encapsulated what HPV-negative cancer is saying to all of us earlier in his slide. So next slide. But a big question is, can we predict treatment outcome in here? There's only a small percentage of people are failing and a lot of people are getting intensive therapy. And can we change that in any way? We want to de-intensify. Next, why do these guys do so well and these guys do so bad? There's lots of theories, but no one's really proven it. And the cell line studies have not in any way supported that. Next slide. So math and HPV, next. So next, if you remember, we want to predict the outcome. Next, understand the survival disparity. Next, problem, the Stransky was too small. Next, we did use the TCGA data. Next, and there were 36 patients who were HPV positive. We put that together. They're independent. And next slide. So this is the HPV positive where they had low mass scores. Next, and this was the HPV positive where they had high mass scores. I'm sorry, HPV negative with high mass scores. And next are the two in the middle. They're intermediate. So you could start to stratify these patients. This was a very underpowered study. It reached significance with all four of these, but if you tried to just look between these two, you would not reach significance because even though there's 305 patients in this study, only 36 were HPV positive because with the TCGA, they wanted like big tumor specimens to do all the different things they wanted to do. So there's a lot of oral cavity cancer. So we need a lot more HPV positives. This is one patient did this to us. Otherwise, this thing could look like that. So if we had like 100 or 200, it might be nice. Next slide. And so you can see these hazard ratios. Next slide. Next. So we've shown here in the data I showed before, the survival disparity is likely that the HPV positives are much more homogeneous than the HPV negatives. And in fact, when you look at HPV-positive tumors that are heterogeneous, they don't do so well. Next. And math is likely a good biomarker candidate to stratify HPV-related head and neck cancers, and its chances are HPV-positive with low math might be great candidates for de-intensification. They just need to be sequenced beforehand. Next. Next. So this is prospective validation I talked about. It's going on in our lab. Patient with oropharyngeal cancer. Next. What's his mass score or her mass score? Usually a man. Next. So next generation sequencing math analysis is being done prospectively. Next. And next. And next. They're all getting platinum-based chemotherapy. Next. And we're really looking at survival. And we're up at about 147 patients now. So we're going to be able to answer this question. Next slide. So math could be incorporated into clinical trial design, allowing low math patients for de-intensification, high math for alternate treatment strategies. I'll give you what I think is an exciting slide. Next. So this is the Stransky data. So if you think about this is the ROC curve, false positive fraction, true positive. You could generate this for any specific disease area that you do sequencing and treat them the same way. You ignore their stage. And so next slide. So remember when I did the Kaplan-Meier curves, we used the median value of 32. Below, higher, bad, above, good. But it's a continuous curve. So if you look at this next slide, if you look at these patients here, 20% of the patients who are above here have a risk of treatment failure of less than 5%. Next slide. And next slide. And if you look at patients with a math above 40, their risk of treatment failure was greater than 95%. So a very heterogeneous tumor. So the idea is that once this is established for a group of patients by sequencing a few hundred, people would get sequenced, their mass score would be calculated, and you would put them on it. However, if you changed therapy or did anything different, you'd have to come back and regenerate this curve that they could be assigned to. Okay, next slide. So better tumor models. Next slide. Same patient, oropharyngeal cancer. Next slide. We know, and we heard from others, there's tumor cells, growth factors, stroma, blood vessels, all in there. Next slide. You know, if we take these out and dissociate them, assuming all the cells live equally when you dissociate them, and next, you end up with cell lines which we think are, for the most part, pretty homogeneous. Next. The mouse model's a little bit better. We think this is going on in there, because when we look by histochemistry, it kind of looks like the original tumor. Next slide. But again, people will tell you after 4, 5, 3, 9 passages, suddenly the xenograph doesn't look like the original xenograph. It becomes a little more amorphous. But we don't know when we could say, is it okay in the first 2 or 3 passages to use it, but not later? Next slide. And so we don't know if we evolve into this or this. And next slide. So what math really allows us to do, and what we've been doing, is comparing the math of a tumor here to the mass score here, the mass score here, the mass score here, and then what happens over time. And next slide. We're also using this as a shortcut that, since there's a lot of complexity early on in the cell culture, to go from here to speed up and increase the efficiency of making xenografts. Next. And then there's a very interesting question. We think these are very uniform, and we predict that when they go in there, they'll do this, but we shouldn't forget the tumor microenvironment and the potential that the tumor can reset itself if there really are tumor-initiating cells in here to reestablish new tumors. And statistically, they may be different in each one. And these are all the types of things that we're looking at. Next slide. So tumor spatial heterogeneity. I don't know if you guys remember this from Gerlinger and Charles Swanton work back in New England Journal of Medicine 2012. This is a renal cell carcinoma. This is 10 centimeters. They did a bunch of different spots, did biopsies, and they sequenced, and lo and behold, there weren't a lot of shared mutations in these different regions. And so they might get a targetable mutation here, but none of the other regions would have the targetable therapy. There was a little byline with it, the end of targeted therapy, and they generate these phylogenetic trees. So next slide. That's an issue for us too. If you think about how this is done, when you take a tumor and you pick spots and you sequence, you can do targeted sequencing, which will not identify a lot of different subclones, which really might find your founder mutation. You can do exome sequencing, like what we're talking about with TCGA, which will identify a lot of your subclones, but not all of them, and start to allow some phylogenetic trees to be done, or you can do deep exome sequencing as identified here, and really, depending on how deep you sequence, find additional subclones. Next slide. And this was actually done. Here's an example. This is from the online data of Gerlinger, and now that I've written all these programs for math and done this stuff, I can get to really any online data set and run my math analysis on it. The data's there. And so basically these were renal cell carcinomas advanced with metastatic stage, and these 4 up here were basically treated with an mTOR inhibitor for 6 weeks, and then biopsied, and deep sequencing was done. Each one of these rows represents a different place they sequenced, and they were really looking at the variant frequencies of some major mutations. These 4 down here, they just sequenced them right off the bat. They didn't do any of that. So next slide. And if you look here, we took all those regions, and we ran our math analyses. But the end result you should see is that when they were treated with the mTOR inhibitor, there were no areas of high intratumor heterogeneity in any of those regions. Next slide. However, all 4 of these advanced tumors had regions of high intratumor heterogeneity when they weren't treated with an mTOR inhibitor. And the implication is these had regions of high intratumor heterogeneity as well. And on a Fisher test, it actually works. But the idea here is when you do this, potentially you're lowering intratumor heterogeneity. And our data would say maybe that's a good thing to do. Should you treat with an mTOR inhibitor before you actually give someone additional therapy? Next slide. But the problem is if you really look at the model, let's say this is our high MAP tumor with heterogeneity. Next slide. This is the drug they used, our mTOR inhibitor. But you could really end up in 2 different ways. You might end up with low MAP because you really have just left some residual sensitive tumors, or you may have low MAP because you now just have mainly the resistant tumor there. And so when you do the next step, which is next slide, treat with therapy, it's possible that this could work and cause an enhanced cure. Next slide. The skepticism in me is this, because I think this is more likely, but I think likely because of the overlap of different resistances that this early step will create some resistant cells that will likely go on to treatment failure when you do more. Next slide. Another final, 2 more things that you can do with math. So math and phylogenetic trees, combining those to look at the origins of intratumor heterogeneity. So if you look at a phylogenetic tree that's generated by deep sequencing, you kind of have a truncal mutation. That's like a founder mutation. That's something that every single cell in there has. And then basically what you do, you look at, there's different ways to do this, but you're making predictions about which different little subclones have mutations. And so if you look here, these were the ones that were treated with the mTOR inhibitor, and next. And you can see that there's really very little high intratumor heterogeneity. Next slide, and next slide. But if you look here, there are 2 regions, as you can see, that have high intratumor heterogeneity. Now you have to do really deep sequencing here. You have to go above like 100 to 150 and start to get into 4 to 600 range to get this kind of information out of a tumor. But if you look here, what you can see is you can kind of see how the heterogeneity that was available along here starts to change from something that's low, suddenly can go high. And here's an example where R7 really starts to go high versus when it was down here, it was low, and you had a p53 mutation. Similarly, next and next, where you basically again have a tumor with low heterogeneity, and suddenly some mutations start to happen, ATM, ME6, and suddenly you have high intratumor heterogeneity. And if you look at high intratumor heterogeneity as not what's there, but just the idea that it's likely something there that can defeat your therapy, it's very important to find out which genes are causing that thing to be there that can defeat your therapy. And if we can find things that could potentially be targetable, unfortunately p53 is an almost impossible gene to target, but maybe there are others, we might be able to pre-treat tumors to make them less heterogeneous without selecting out the resistant ones and potentially go further. Next. This is the final slide. This is very confusing. I get confused myself when I do it, but I'll try to explain to you. So I tried to say, how can what we're doing inform targeted therapy? You guys heard about mutant allele frequency, the idea that Joe brought up very nicely. Hey, some of the mutant alleles, only 10%. The implication is 10% of the tumor has it. Maybe have a complete response to that 10% of the tumor to like a PI3 kinase inhibitor, and your medical oncologist will tell you after a while you didn't meet RECIST criteria, and that drug would then fail the therapy, but actually did the thing it was supposed to do against the 10% of the tumor. So we started to look at this, and next slide. What this basically here is I took PIK3, which in the oropharyngeal portion of the TCGA data set that's HPV positive has a 41% rate of mutation, of activating mutations. If you look at, and you guys were talking about corrected mass, but this is really tumor cell fraction. So we corrected this for stroma and immune cells. There are actually programs on the Broad site that will do that to the data. You could probably use it for your transcription factor analysis as well. we got rid of that. So this is corrected math. And basically what that tells you is things that don't have a high enough percentage of the cells having the mutation are likely not to respond. So if you think about what you should do, in your first step, what you kind of want to do is to say, hey, all these here have the potential to respond to the therapy, to a targeted agent. But then if you ask yourself, the solid have high math, the blue are HPV positive, things that are going to have high math are likely not to respond. So you want to focus on the circles. And then things that are blue are likely to respond. And when you start to think about that, if you look at everything that was possibly there, it's really going to be the blue circles that we would expect the potential for a complete response from the targeted therapy. And that all of a sudden you go from, hey, I have 39 patients in this trial, but you're really saying I'm only expecting 6 of them to actually give me a really durable response, if that makes sense. Next. Finally, can heterogeneity be targeted? I'll just tell you the only gene that correlated with high math scores was mutant P53. It's a little bit worse when it's disruptive than when it's non-disruptive. And when P53 is mutant, you rely a lot on these G2M checkpoints. So it's possible that tumors with very high intratumor heterogeneity have really disabled this P53 checkpoint and may be very susceptible to WEE1 or CHEK1 kinase. Okay, and that's my last slide. Thank you. Oh, one last thing. Next slide. You can just hit it 4 times. If you could hit it 4 times real quick. Just I'd like to thank Ed and Rose and Rebecca and Yin Ren and Aaron Tord for